Good morning from Regensburg to Essen. Dear colleagues, dear organizers, thank you very much on behalf of the whole operating team, Professor Pfister, Professor Kasprzyk, for this opportunity to present these two live cases today to you. I hope you're hearing me well. My sound is a bit low, so I would like to ask you to please ask your questions quite loudly, if there are any. So I'm going to present our first case. Our first case is the next slide, please. Is a 49-year-old patient who had a polytrauma in 2005. The patient suffers from hypertension and COPD. The next slide, please. So this patient received emergency Tevar due to a traumatic aortic rupture in 2005 with partial overstenting of the left subclavian artery. And the colleagues, 2005, saw that this patient had a bird's beak effect, so they tried to stabilize the graft with a palmar stent inside it. The next slide, please. So 2005, this was the situation. In 2012, the next image, we saw that this stent graft had collapsed, the proximal end. The palmar stent had migrated a couple of millimeters. So at this point, the next slide, we decided to treat this patient from the left subclavian artery and try to fixate the proximal end to the inner aortic curvature, which had some results in the beginning. Next slide. However, during follow-up, we now see in the next image that 2018, the graft has collapsed again. We're going to be using the new CTAC device to extend this over the left subclavian artery to deal with this bird's beak effect. And we know that we can tilt this device, we can use active angulation control in order to position it properly in a perpendicular axis to the aortic arch. Next slide. So the plan is access over the left groin. We're going to be using an upper access from the left carotid artery for two reasons. First, to use it for angiography, and secondly, in case we do partially overstent, we have very small distances, we do partially overstent the left carotid artery to be able to right away use a Chimney as bailout. We have also discussed this patient extensively with our thoracic and cardiac surgeons, so we are actually able to do a sternotomy if this proximal extension does not work, and the patient knows so as well. We had some problems catheterizing this palmar stent. We were behind this palmar initially. We then used the pigtail catheter to go over the palmar stent, and we yes, this is the maneuver with the pigtail catheter. And after that, when we had the Landerquist wire inside, we used the endovascular ultrasound to verify this is the endovascular ultrasound wire catheter to verify that we're in the right position inside the palmar stent. We then used a maxi balloon to dilate the palmar stent to its full diameter to 25 millimeters because we don't want to have this mismatch between the 28 millimeter prosthesis and the palmar stent. We then proceeded to advance our stent graft. We had some problems getting over this proximal stenosis. But in the end, we managed to get over this proximal very difficult spot, and we have now positioned our stent graft, and we have done an angiography over the left carotid axis. We have pulled back our stent graft a bit, and we are now ready to deploy. I'm going to pull back my stent graft up to the orifice of the carotid artery, and at this point we're going to open up our graft. So we're opening to half the diameter. Okay. So, and now we're going to use angulation control to tilt this in the aortic curvature. Okay, we're going to now do an angiography at this position. Apnoe bitte. Okay, I think that our positioning is very good. Are there any questions at this point?
Did you do a left cervicotomy to get the pictal catheter down?
Yes, we did a small incision to prepare cut down access for the left carotid.
I think that's great. It's very safe, so that you can.
Yeah, we do it as safe as possible.
Yeah.
Because we know we have very small, like I said, very small distances, and we need to be certain that we're not overstanding anything, covering anything.
Very nice. Do you consider more angle now?
Yes, we're giving more angle. Okay, so that's nice. And at this point, we will deploy fully to its full extent. We do not expect it to fully go off. We also see the stenosis. And now we're going to pull back our deployment system and try to dilate with a coda balloon to solve this bird's beak problem. And we see that it is very nicely. Hopefully we won't be having any recoil at this point. Nächste Spritze bitte. So, Aorta geht zu, ne?
You lowered the blood pressure before?
Yes, the blood pressure was at 80 systolic before doing this maneuver.
Yeah. Oh.
And we have now dilated our stent graft. It seems to be okay. We're going to do an angiography at this position. So, Apnoe bitte. Und ab. Nice. Okay. So, we have at least angiographically good flow to the left carotid. We're going to use the ultrasound to verify this at this point. We have a nice positioning in the aortic curvature over the arch, and we have seen that even in this very steep angle, you can use this stent graft to overcome this problem. Like I said, technically it's driving the stent graft to its technical limits, but I think this is an acceptable result.